Okay, so I will call back to order the special meeting of the Watsonville Community Hospital Board of Directors for Wednesday, January 14th, 2026 at 3:59 p.m. Rosie, if you could please give us the roll call.
Yes. Director Friel?
Here.
Director Gallagher?
Here.
Director Cox is absent. Director Pimentel is absent, and Chair Nunez.
Here. Okay. We have nothing to report out of closed session, and I'll now turn to staff for any potential agenda modifications for consideration. No. Seeing none, I'll move us on to public comment on matters not on today's agenda. So these are public comments of 2 minutes for matters not on today's agenda, and we have 3 discussion items on today's special agenda. So anyone online wishing to speak on any of on an item that is not on today's special agenda? Okay, seeing no raised hands online. Anyone wishing to speak on an item that is not on today's agenda? Okay, I'll close on the public comment, and I will entertain any comments from board members at this time. Any comments? I'll move us on from the comments from the board members into our discussion items. Item number 1 is a core linen service agreement amendment. And we have a recommendation to pass a motion to approve the signing authority for the Watsonville Community Hospital Chief Executive Officer, Chief Financial Officer, or Executive Delegate for the First Amendment to the core linen service agreement, extending linen and textile rental services through November 17th, 2026. Steve, can you read it?
Yeah, thanks, Chair Nunez. So you said it well. The agreement with Core Linen Services, formerly Crothel, is approximately $345,000 per year. So it is the signing authority that comes to the board. We are adding microfiber cloths that increases the cost slightly. But mostly no escalation, otherwise no escalation during the contract term. Our director, Susan Sample, is here to help answer any questions should any board members have any. But otherwise, this is a favorable contract for us to continue with limited to no cost increase for our linen services.
Yeah. Any questions from the board? No. Okay, no questions. I do need to open up to public comment on item number 1. So anyone wishing to speak on item number 1? Okay, seeing no raised hands. Anyone online wishing to speak on this item? Seeing no raised hands, I'll close down the public comment, and I will bring it back to the board for an appropriate motion and any closing comments. Move approval. Thank you.
A second.
Thank you, Directors Gallagher and Friel. I'll take roll on this item. Director Friel?
Yes.
Director Gallagher?
Yeah.
Chair Nunez?
Yes.
With Directors Cox and Pimentel absent.
Okay, we'll move on to item number 2. This is a Central California Anesthesiology Services Agreement. I'm very happy about this. A recommendation before us is to pass a motion approving signing authority for Watsonville Community Hospital Chief Executive Officer, Chief Financial Officer, or Executive Delegate to the Central California Anesthesiology Solutions CCAS agreement covering anesthesiology services for the 3-year period beginning February 1st, 2026. Steve.
Yeah, so thank you again, Chair Nunez. So we have, obviously our anesthesia services are critical to our operating room and OB services that we provide. We have had an agreement for the last number of years with LifeLink Corporation. They have been providing our anesthesia services, both with certified registered nurse and anesthetists, as well as the anesthesiologists. We let LifeLink know late last year that they were part of as we extended their contract through the end of January, that they were going to be part of a bid process that other organizations would be able to bid on the services. So they provided a proposal, and we got a proposal from Central California Anesthesia Solutions. Our obstetricians and surgeons and others who work in the surgical services area had the opportunity to interview the 2 groups and look at the 2 proposals, and ultimately and unanimously CCAS was selected. And so it is going to be a group that provides the right level of service and has a leadership team that is here local. And so we really look forward to partnering with them. The annual cost of the contract is just over $2.8 million, which is over $1 million annual savings in the previous contract with the same and better coverage. So we are looking forward to that, and happy to take any questions. And we have a couple of directors here who help us oversee these services that can help answer questions that I can't.
Any questions for staff on this item? No? Okay, I will open up for public comment on item number 2. This is a Central California Anesthesiology Services Agreement. I'll go online first. Anyone online wishing to speak on this item? Okay, seeing no hands raised, anyone in person wishing to speak on this item? Okay, seeing no hands raised, I'll bring it back to the board for an appropriate motion. Any closing comments?
Can I ask a question? Steve, are the Central Coast anesthesiology people credentialed and ready to go to work? I'd heard something like February 1.
February 1 is the start date of the contract, and they will be ready by then. We do have a number of them that are already working their way through and already into the credentialing process. Then they will be ready by February 1st.
Okay, thank you. Yeah. Okay, I'll entertain a appropriate motion.
I'll make a motion to pass this anesthesiology services agreement.
Second. Thank you.
Thank you, Directors Friel and Gallagher. I'll take roll on this item. Director Friel?
Yeah.
Director Gallagher?
Yes.
And Chair Nunez?
Yes, and
Directors Pimentel and Cox absent.
Steve and your team, just thanks for your work on this. I know that this has been something that our team has been asking for quite some time. So thank you.
I have been getting this question. Yes.
Okay, we'll move on to item number 3. This is the Watsonville Community Hospital ICU staffing update. We will have a verbal update regarding the ICU from our CEO, Steve Gray. Before we start the presentation, before we start the update, I do want to take a moment here just to clarify that there are no votes happening today regarding the ICU or anything associated with the ICU. And so I just want to make that clear that the board is going to receive a report from our leadership team about the situation, about the next steps, and wanted to make sure that we understood that there is no vote happening today. There was never a plan for the vote to happen today. But I thought as a board chair, it would be important to hold some space for our staff and for our community to hear about what's happening in our ICU, hear about the next steps, and also to be able to get feedback on the situation that we're in right now. So with that, I'll hand it back over to Steve,
Yeah,
their CEO, to give a verbal update.
Thanks, Chair Nunez. So I want to start this with really a continued tone of collaboration. I think we've had some really good conversations with the nurses and the nurses union over the last few days. And I really appreciate that. And I want to make sure that we have the opportunity to continue that. I think that's really important. We're really in this together with all of the challenges that face our hospital and healthcare in general. And so I hope that, and I look forward to being able to continue to work collaboratively on these solutions because they're hard. As a little bit of background and what has come forward is the beginning of last week, we learned that one of our staffing agencies where we get traveler nurses and other travel staff from was pulling their nurses from our facility. It wasn't because we missed a regular bill. It was because they were asking for a large upfront payment that we couldn't make. It's just the reality of the financial situation we're in. So they said, well, if you can't make that, then we're going to pull our nurses. And that included 3 night shift ICU nurses. And that's a pretty big percentage of our night shift ICU staffing. And so when we learned that, we, and really the folks to my right, Trina and Margaret, reached out to the ICU nurses and the union right away and said, here's the situation. Can we get together and talk about how we can solve this? And so that started a string of meetings that occurred at the end of last week and into Friday, and then starting at the beginning of this week as well. I really want to acknowledge the nurses in that department because I know that a number of day shift staff nurses have stepped up to staff some of those night shift holes. We were able to fill a permanent night shift position this week. So that's really good news. So the the gap there has shrunk. To the extent that we can get those people, get those new nurses trained and oriented with patients in the department. I want to acknowledge that this has caused a lot of consternation, and that's totally understandable because it felt like the hospital was, closing or potentially closing the service. That wasn't the intent, but we also knew that if we couldn't staff the night shift, then it was going to be really hard to keep the ICU open. And so we really appreciate the collaboration to be able to come together and come up with a solution. There is a solution, as I understand it, for 4 weeks to have that staffing plan, and that we'll continue to work over the next few weeks to figure out the staffing model that will continue to move forward, whether that's continuing to have those rotations of day shift folks into the night, or if we're able to successfully recruit new nurses into the hospital as those positions are posted. We hope we'll be able to come to that agreement. Obviously, any kind of permanent closure of any service would become a public conversation that we would have with the community, with the staff. We want to do that collaboratively, and then the board would ultimately have to vote on anything like that. But at this point, the ICU is available for patients and for patient admissions. We really appreciate that. We want to be able to take care of patients in any way that we can, including in this service. And we'll continue to collaborate and work together on being able to do that. We've talked a lot about the financial situation of the hospital, and so that's kind of where I want to loop back to my beginning conversation, that collaborative conversation. I was pretty transparent with the nursing group at our last PPC and NQF meeting in December about kind of the things that we're facing and the things that we're working on in terms of longer term strategies, finding a strategic partner to help the district run the hospital, all those sorts of things continue to be really important. We were dealt a hand with a starting financial situation as a district where we were starting with very little, right? Very little cash on hand on day one as a district. And we have been dealt a further hand by federal legislation that makes it really, really difficult going forward for hospitals and independent districts like ours. And really the only way that we're going to get through all that is to figure all this out together. And so I do want to take a moment to acknowledge that the consternation that was created by these conversations and the sort of the back and forth dialogue with the ICU nurses and the union about what staffing model was going to work and what wasn't going to work, and that caused the challenges around, is the unit going to close, things like that. That's brought all of you here today. I mean, the communication of things ultimately, starts and ends with me. So if there are things that I need to do better to communicate better and make sure that there's clarity around the intentions and where we're at, I apologize, and I'll make sure to continue to try to do that better so that we can have that open dialogue. And I just want to, I'll come to PPC again. I think or NQF again. I think it's this Friday, right? We'll continue to talk about it. We'll continue to collaborate and talk about what's going to work and what we need to do together and make sure that we're moving this place forward and keeping this place available for our community for years to come, because we all want that same thing.
Any questions of the staff before we open up for public comment? Okay, anything else from Trina or Julie or anything that we want to add before we open it for public comments? All right, can I get a show of hands who would like to speak today? Okay, I won't ask you to line up because I know that we are a little scrunched for space, but we'll give 2 minutes and we'll start with a few in person. And then if you do want to speak on this item, please raise your hand. And then Rosie, if you could write them down in sequence as they start to raise their hand.
Yep.
I just have one request. Could we please allow for Dr. Ravago to go first, just because he has patients to care for and we
Sure.
want to be respectful of his time? Thank you.
Yeah.
Good afternoon, board of directors, and thank you for allowing me to speak. I'll be brief. I have patients to see. And Steve touched a very important word here for everybody to hear. It's the word collaboration. I've worked in this hospital for many, many years. Me and Dr. Gallagher here worked in the ICU for many, many years. And we have this season of very, very low census. It lasts for several weeks, sometimes months. But we were able to get over those times of low census. The key there is when we do get to that point of having low census, is the nurses and doctors and administration would get together and figure out what's causing the low census. There was a time that it was explained because we didn't have enough specialists. So we went out there and started recruiting doctors. There was a time that it was just lack of enough doctors to cover the critical care of the patients. And then there's some times that we just had no explanation. Patients were very healthy. So the thing there is we just need to be careful of how we disseminate the news of those census and understand that this is a normal cycle, normal pattern that happens every year. But we also need to know that we cannot continue to move to that path of thinking that we're going to close ICUs. Now, but it should not happen. Once we hit that road wherein we close the services of ICU, it's a continuous downhill suicide, I would say. Because all the services in the rest of the hospital require ICU support. ER will require ICU support. Otherwise, ER will see cases that are critical and you don't have an ICU, everything will go up north. Most of these doctors now.
Dr. Ravago, if you could wrap up your comments. Yep.
Thank you. But the point there is we should not move to closing ICU. The hospital knows that, everybody knows that. To save and continue to reserve our revenues, we should continue with this.
Thank you.
Thank you.
I'll just, I'll make an announcement. So 2 minutes, I apologize. I said at the beginning, but I forgot to reintroduce it. So 2 minutes to speak. Rosie will have the timer, and again, apologize. Happy to speak after the fact, after the meeting, emails, phone calls, that sort of stuff as well. I'm open to that. And if there are any questions, we won't answer it in real time just to respect everyone's time, but I'll take a note of them. Steve will take a note of them. And then when we're done with public comment, we'll come back and answer and work through some of the questions that we have. Anyone else would like to speak during public comment? Please, yes.
My name's Roseanne Ferris. I'm a registered nurse here. I work in the ICU. I've been here 30 years and I'm a chief nurse rep for our CNA union. The past Thursday, the ICU nurses, physicians, and all frontline workers were blindsided with the threat of closing ICU by January 11th due to the inability to pay and keep existing night shift traveler nurses. This threat is not only a threat to the safety of all patients in our hospital, but a threat to the broader community, and would ultimately result in patient death and the acceleration of closing our hospital. While the CNA nurses, stakeholders in this hospital have been endlessly organizing against this closure, we know that this threat is only temporarily diverted until February 7th and could be any service at any time. We need the board to use its oversight on these seriously dangerous plans. We know the hospital is in dire financial crisis. In developing a distressed hospital turnaround plan, the safety of our patients has to come first. As stakeholders, the nurses have repeatedly gone out and pulled other stakeholders, including the community and elected officials, together to keep this hospital open. True leadership happens when the board, for example, reached out to the CNA nurses to help get Measure N passed, to buy back our land, building, and have funds to reinvest in our hospital. Together, we made that happen. Now it's time again for true leadership that has a turnaround plan that will not be on the backs of patient safety, and our time is valuable. We need to be able to focus it on getting the support needed to stabilize our hospital financially, and we are calling for true leadership and the willingness to do the work that it's going to take. Thank you.
Thank you.
Hello, my name is Louise Pierce, and I have worked as a nurse here for almost 20 years. I work in CCU, and I want to continue working in CCU. I'm committed to this community and a collaboration with our hospital. We, the nurses at the hospital, are sounding an alarm to our community to help find a solution to secure CCU and all of the services of our hospital. Most recently, critical care has been threatened, and we've come together with a safe staffing plan to get us through 4 weeks. As we find solutions together, please don't reduce our services. Would you close labor and delivery? Would you close the OR? Would you close our medical surgical unit? We've already been here to protect our IICN, and we're showing up today for CCU. The threat to slice out the critical care department is a short-sighted threat that risks staff retention and recruitment. What I see today is that we are in a financial crisis, and we're desperate enough to start cutting parts of our hospital that are vital. What will be left, and how will our hospital function without its vital parts? Let's come together to find a solution. We are here in good faith, as we always have been, and thank you for listening.
Thank you.
I'm Gina Galucci. I have been in ICU and then Watsonville Hospital here for 40 years. I have been the charge nurse in all shifts, and I've worked many departments in the hospital also. My concern about the ICU is that the biggest thing we always had to fight for and keep, which was our main #1 thing, was keeping our accreditation. If we close that department, whether it's for weeks, months, year, whatever, we could lose that accreditation. We could never get that back. Okay, that limits our services that we can do from there on. When I started working at this hospital, we were doing vascular surgeries. We were doing stenting. We were doing a lot of different things here and stuff and all. We were up and coming hospital here and all. And then, of course, we got hit with recessions, all kinds of other problems too. But we always wanted to keep our accreditations perfect, so that we could expand and that we could still be able to rely on the skills and abilities that we have here and all. My second concern was, in the 40 years I've been here, I've been to a lot of these meetings when we've had this problem about money. The hospital went out and was soliciting every major business in the area that had insurances for their people that work for them, trying to get us on their contracts so they could come here for all their services. They could come here for their lab work, they're delivering their babies, having surgeries done, x-rays, any kind of preventative care we offered here. We pushed really hard for that. And I'm hoping that the board is still financially doing those kind of things, trying to get us on everybody's contract or everybody's PPO or whatever. Every now when you open up your insurance papers and all, you start looking for your doctors or your hospital. Not accredited, not on the list, not on the list, not on the list. Why aren't we on these lists? So.
Thank you.
Hi, my name is Annabelle Covington. I work in delivery and I've been here for 24 years. I'm actually going to read a statement from a former patient. She couldn't be here today, but she allowed me and sent me this to read to you all. To whom it may concern, I am writing to express my deep concern regarding the potential closure of our hospital's ICU. As both a nurse and a former patient, I've seen firsthand a big impact this unit has on our community, and I fear what it's lost with me. Recently, I experienced a severe postpartum hemorrhage following my discharge from another hospital. My mother, also a labor nurse, recognized the severity of my condition and brought me to Watsonville Community Hospital, trusting in the expertise of her colleagues. I was supposed to have a simple procedure that ended up almost losing my life, but the ICU stabilized me, saving my life. I wasn't stable enough for transfer because I became septic and my blood pressure was low in the 60s, needing immediate ICU interventions to save my life. Without it, my outcome could have been tragically different. As a nurse, I understand the critical difference the ICU makes in such situations. If I were to have another child, I would not choose a hospital where an ICU, without an ICU, knowing my history. The ICU is not just a unit, it's a lifeline for patients needing critical care. Please reconsider the closure of essential services.
Thank you.
So thank you for the opportunity to speak. My name is Lisa and I have worked here for over 37 years and I work in labor and delivery. I want to acknowledge them and appreciate the decision to temporarily staff the CCU through mid-February. That pause is important. However, the underlying concern remains as this issue has not been resolved, only deferred. The potential closure of CCU would have significant and potentially devastating effects across the hospital if not fully evaluated. This concern is not limited to one department. I am speaking on behalf of the obstetrics unit, but the absence of CCU would impact multiple areas. The OB, the emergency department, med-surg, telemetry, PACU, OR, any procedural unit where patients can deteriorate unexpectedly. In OB, complications such as hemorrhage, severe hypertension, severe sepsis, anesthesia emergencies can escalate rapidly and without warning, and I have witnessed them all. Without on-site critical care, these patients would require stabilization and transfer during time-sensitive events. Similar risks exist for other patient populations throughout the hospital. What remains concerning is that there is still no comprehensive unit-by-unit assessment of potential adverse outcomes. No clearly defined plan for how patients would safely be cared for or transferred. No meaningful involvement of frontline staff in determining how safety would be maintained beyond this temporary period. Proceeding toward a decision without this work exposes patients to harm, increases hospitals' regulatory liability and accreditation, and the risk and accreditation risk should an adverse outcome happen. This hospital has served this community and for generations, and decisions like this must be made with that responsibility in mind.
Thank you.
So my name is Ann Lucero, and I collectively with ICU nurse here for 35 years, something like 14 full-time, and then came back, went to Cabrillo. I've been just retired after 25 years of being a nursing instructor there. I agree with a lot of things that our friends have said, so I won't repeat them. One thing I can tell you as a faculty member of Cabrillo College nursing faculty, where if they raise their hands, majority of these people, or at least half of them, are Cabrillo grads. That's what's kept this place whole all these years. Cabrillo's here for you. But it takes at least 6 months to a year to make an ICU nurse out of a new grad. It takes several months, even with a great tele nurse, to make an ICU nurse. So if you close, if you pause is death, because there's 8 hospitals within 40 minutes of driving that they can go get jobs. When we went on strike in the 80s, 17 of our nurses within 24 hours had jobs and couldn't come and walk the picket line because they all got hired. When you even have a whiff of downsizing, your nurses will leave because they can. We've got this core in ICU that's been here through thick and thin. They want to stay. But if we get any closer to this discussion, they will go and they will get hired in 24 hours and you won't come back. And the Cabrillo College grads won't come here either because they don't want to put their eggs in a basket that's empty. Good luck. My heart is with all of these people, as it always has been. I live in the community. I hope you are as honest as your words. It's not always been the case with administrators. Good luck.
Thank you.
Hi, my name is Connie. I'm one of the newer nurses here in the ICU. I came during COVID times as a travel nurse. And then I just fell in love with the community and the support of the nurses in our ICU. I wrote something, but this past week, we were blindsided with the threat to close our ICU. We work together as nurses to fill those staffing gaps that has been caused by the hospital's financial crisis. We did that to ensure that our ICU remains open and that patients will have safe care. I myself am working both days and nights, switching between two to just many of our nurses are. Patient safety must be the foundation of every decision. Anything less breaks the promise this hospital makes to this community. As nurses, we show up, we speak up, we intervene when patients are at risk, but commitment alone isn't enough without support, transparency, and clear planning from those with authority. This hospital is not an abstract institution. It is a promise to this community, a promise built over decades by nurses, doctors, and staff who have safeguarded lives. Keeping that promise requires all of us together, accountable and unwavering. Thank you.
Thank you. Anyone else wishing to speak on this item, please?
Hello, everyone. My name is Rajinder. I'm a resident here in Watsonville. And I just want to say that we should not close CCU or an ICU. My father was admitted here a year and a half ago for a regular routine checkup. It was sepsis. If it wasn't for the department, he would not be here to this day. I've been a nurse for over 2012 over the hill, and I live here, and this is a wonderful community. We're here for the people, and education is power. Education is knowledge. Nurses educate patients to prevent further complication, readmission to hospitals. And if we don't have that services here, problems, and we don't want problems. So please save the department.
Thank you. Anyone else wishing to speak on this item? Okay, I'll close down the public comment. I'll bring it back to the board. Or anyone raise their hands online? Okay. No raised hands online. I'll bring it back to the board for any additional questions or comments on this item before we adjourn today.
Ralph, sorry. I do.
Okay, go ahead.
Move down a little bit or stand. Thank you all for coming. We needed to do that closed session before we met with you. Thanks for sticking around for an hour. Given that we're a 106-bed hospital with an average daily census of 30 and a $20 million loss for the year, it's no surprise that utilization and financial numbers for ICU look awful. If applied to other departments, that same analysis would show we can't afford to do surgery or obstetrics either. Talk of closing ICU is the wrong conversation based on the wrong analysis. Closing ICU in hopes of salvaging the rest of the hospital is a fallacy. All of us with medical backgrounds understand that closing ICU will decrease the number of surgeries, admissions, deliveries, ER visits, and it'll only hasten our demise. Even temporary closure for reasons other than patient census would lead to loss of staff and inability to reopen. Cutting essential services leads down the path to hospital closure. Even CHS and Quorum, who cut services and staffing, never closed ICU. I watched CHS and Quorum fail year after year by trying to cut their way to profitability. ICU is the core service. It's the tent post that holds up all other patient care services. It's the safety net. When patients from other departments, including ER, surgery, PACU, specials, telemetry, med-surg, OB, and even radiology code or become unstable, they're admitted to ICU and stabilized. A code nurse or a code team is simply not enough. The logistics of transporting clinically ill patients to other hospitals is slow and difficult at best. Without our ICU, people who could have survived will die. The doctors and nurses who take care of patients in ICU work hard to keep the lengths of stay short as possible. They promptly transfer stable patients from ICU to another area in this hospital or to other hospitals. Their goals are good patient care and saving money for Watsonville Hospital. I'm going to skip that part. It's already been covered. The cyber attack certainly caused our finances to unravel. The cuts to Medi-Cal and other governmental payments appear as insurmountable obstacles. But month after month, we've watched the patient census hover in the low 30s without taking actions to change it. Our market share has fallen to 38%. We haven't gone to the community to encourage people to return to Watsonville Hospital nearly enough. Problems with anesthesia coverage have forced surgery schedulers to turn away cases and cancel cases in appalling numbers. Surgeons who used to routinely bring their elective cases here don't do so anymore. Problems with CT, MRI, and echocardiogram availability have also had significant impact. The cath lab remains mostly idle. Lack of communication with medical staff and hospital staff has usually left people in the dark, wondering and worrying about the future of the hospital and their livelihoods. The above are criticisms of our performance so far, but there are also opportunities for improved services and increased patient volumes. There are also a number of other ideas I have about increase in patient volume. Outreach to the existing primary care practices in town by establishing a primary care liaison would be of mutual benefit. Having community organizers help us rebuild connection to the people who live here could raise our census and improve market share. Opening a private practice OBGYN office would increase the number of deliveries. Appointing a medical director for Coastal Health Partners and a chief medical officer for the hospital would solve long-standing clinical issues. Since Watsonville is a working class community and this hospital embodies that culture, marketing to labor unions throughout the region could attract additional patients. There's no shortage of good ideas, but all of us working together as a coordinated team rather than against each other is now more important than ever. We're a hospital that serves poor people. The economic and political systems function to keep poor people poor. We're going against a strong current by providing medical care here. The economic and political systems are arrayed to make us fail. We need to think and act far more boldly and effectively than we have. No doubt we need an infusion of capital, but we also need short and medium-term plans that get us through this immediate crisis until the midterm elections, until Democrats in Congress are able to reverse the Medicaid cuts and approve Prop 9, until the county's proposed half-cent sales tax revenues start to come, until Watsonville Hospital monies held by the Health Trust are turned over to us, or until aggressive fundraising starts to pay off. I know of a story about a long-distance road race. It's from Death Valley to Mount Shasta. It's over 100 miles. Some years ago, the guy who was expected to win the race is over 100 degrees. He gets halfway through Death Valley and he's nauseated and dizzy and vomits and has to lay down on the ground. He gets some fluids, and while he's laying there, he gets the idea, maybe the race starts here. He gets up and goes on and wins the race. I think we need to get up and go on. What we need at this point, in order to achieve all these things, is leadership, courage, cooperation, and tenacity. We cannot cut our way out of this. Any move that decreases patient volumes is a move in the wrong direction. We need to grow. Thank you.
Okay, I do have a couple comments. I want to talk more, few next steps, what this year looks like, what last year has have been. But before I talk about that, I want to talk about, what a potential closure of any department would look like, right? It would not look like this, would not be a 2-day, a 1-week smash and grab decision. We're going to do this without any sort of public input, any sort of input from our staff, from our physicians, from our community partners. We understand that. And if this board were to potentially discuss or weigh a potential closure of any department, this would be a months-long, really intricate and a thorough process where we would look at every single point of data that we have. And I know that data is hard to come by at this hospital because of our technical limitations, but patient safety would be at the center of it, and of course community impacts, not just for folks who live in the Pajaro Valley that who this community hospital serves, but also throughout the entire region, all the way up from Boulder Creek, all the way down to the southern tip of the peninsula, right? We understand that we are a critical linchpin hospital on the Central Coast, and while we can continue to make decisions here locally, we also have to be cognizant about the impact that we might have on healthcare in general in this region if we were to close down any sort of services or alter anything to that measure. At our December meeting, we did a couple things, and I think that that's one of the reasons why there was concern as to whether or not we were possibly closing the ICU down temporarily or in the long term and all those things. One thing that as a board chair and as a member of the board and trying to live up to the fiduciary responsibilities of ensuring that this hospital can continue and succeed and will be around for decades, gave me pause is we approved a budget with a loss in it, right? I made the comment there that typically as a government agency, that's a no-no. You don't approve a budget with a loss attached to it and expecting to make up that loss, given everything that is going to happen to healthcare this year. And we know that some of the impacts associated with HR 1 have not yet hit, and that is at the federal level. And we also know that as of January 1st, the qualifications for people with undocumented status have changed, and our community serves quite a few patients, or our community hospital serves quite a few patients from our community who have or will not be able to continue to qualify for Medi-Cal, not be able to qualify for Medicare and all those other services. So we know we're facing a really difficult financial challenge. And so seeing that and approving a budget with a loss in it at the end of last year, as a good steward of the financial stability of the hospital, I asked our CEO to please bring forward the initial conversation as to what would it look like if we were to start to weigh a potential closure of any of our departments. And so we presented essentially the operating costs, and that's just one data point, right, of what of the departments across our hospital, starting that conversation of saying, if there are several things that continue to break wrong for us as a hospital, what are we willing to do? What do we need to do? And so that was the beginning of that conversation. And like I said, any sort of potential, reduction of service is a months-long, half-year-long kind of conversation that would have a lot of input with what I would like to begin a potential ad hoc committee that would be able to run these town halls, not only here in the hospital, but with our community partners, with our community and our other healthcare partners to actually think about the impacts of a potential loss of the department. And so I want to be 100, 1000% transparent and frank with you that that is something that as a member of the board and as the board chair, I have to do and I have to think about and conversations that we need to at least have in full transparency. I also, at the same time, have been a resident of Watsonville since I was 8 years old. And I understand this community. I understand what this community has been through. And I know some of you can do the math and say I'm 33 and say I've been working here longer than you've been alive and I understand this hospital more than you do. I get that. And I'm trying to take all of that into account as we're making decisions and as we're planning forward into 2026. With that, I think from administration, from the folks who spoke today, from my fellow board member, the message that we really send out here today is that the only way that we have been able to keep this hospital open up until this point is by banding together. I heard a lot about banding together during the bankruptcy in late 2021 and in 2022 and raising the 60-odd million to pull it out of bankruptcy and start it as a publicly owned district. And then I heard and remember the days of handing out walking sheets and packets to Roseanne during the Measure N campaign on Saturday and Sundays and Mondays and Wednesdays. And so when we have had our greatest success and when we have been able to get over the hurdles, it's when we have been working together. And I think that now is one of those moments where the feedback that I heard today, and I'm very happy, and one, that our staff worked quickly to put this item on the agenda so we can have this discussion. But two, that the feedback is not, you're doing a bad job and you should be ashamed of yourself, but you're doing a bad job and let us help. Let us be a part of the solution. Let us think about how we get through this together. And so there are several things that as a board, we are currently engaging in that we think will help us get through this really difficult time, right? As Steve mentioned, we're exploring potential external partnerships with other healthcare providers in this region. That is something that continues to, conversations continue. And we hope to have a resolution in that by the end of the first quarter of 2026. Alex, Director Friel and I have been working very, very hard to come to a potential conclusion of that will help the hospital weather these really difficult times. Another thing that we've been working on, and I've been working very closely with our CEO on and our community partners is continued advocacy for additional dollars coming down from the state of California that have become available through the Rural Hospital Transformation Program. That's the $50 billion that were set aside to help rural hospitals and other rural healthcare providers throughout the nation from RFK Jr. and from, it's funny to say this, Dr. Oz, who now runs the CMS, the Center for Medicaid and Medicare Services. State of California just got $233 million of that. We feel that we serve a rural population within not only our region, but within the state of California. We deserve some of those dollars and would love to speak to all of you and our community partners about potential advocacy to our state representatives to get some of those dollars to help us with the things that Director Gallagher said, which is a cash infusion, which this hospital needs in order to survive 2026. We know that, very happy that the County Board of Supervisors sent a letter of advocacy as we did in December. And just yesterday, our Watsonville City Council also approved a letter of advocacy to HDI, who runs and oversees hospitals within the state of California. So I do want to say for all of you who might have come in today thinking that we were going to have a vote, one, as our CEO did, I want to apologize for any of that sort of, high blood pressure that might have created, right? Any stress that might have created. We're not and did not plan to have any sort of vote today on potential closure or any of those things around the ICU. So if you took time off from work, from your family, for any previous responsibilities, I want to just take a moment here just to apologize for that. And at the same time, thank you for taking the time to be here and for sharing your thoughts with us. I think all of this helps us as we're thinking about what are the next steps ahead. And so I think I'll end sort of with the same theme that we had talked about today, and that was the through line of a lot of our comments, which is now's the time for us to come together, right? We understand what is at stake here. We understand that it's not just jobs, it's not just this hospital, but it's the healthcare system throughout the county, throughout the region. And that it is bigger than Watsonville Community Hospital, but it is centered in Watsonville Community Hospital, right? And so we have to care that much more. And so just thank you for being here today. Thank you for taking the time to come to speak to us. I say phone calls, I say emails, I say all that stuff. And I mean it, I make myself as available as I can. Have a full-time job, have a beautiful 3-year-old son. But I try to make myself as available as possible. And I know that the entire board does that as well. If there's anything that we can leave you all, and I know it's 4:50 and we'll wrap up here. It's just that I hope that you leave here today knowing that we are aligned as a board with what you guys are saying. We were not and did not join this completely 100% all volunteer board to come in here and cut services, right? We're not here to reduce services to the point where this hospital is in a unstoppable downhill slide. That's not what some of us were appointed and others were elected to do, right? This is what we're here to do, is to continue to expand services, to bring back services to Watsonville Community Hospital to ensure that it's stable for generations to come. Like I said, I'm a longtime Watsonville resident. My wife also grew up in Watsonville, and we expect to have our kids here. Graduate Watsonville High School just like we did, and to benefit from the services and the safety net that Watsonville Community Hospital provides. And so, again, we're aligned on this. I think next steps, we do have a board meeting in January. We'll likely talk again about any sort of updates that we have, not just with the ICU, but also on the potential process, because I think that for me as a good fiduciary, in my fiduciary responsibility for this hospital and the district, yes, we have multiple things that we are fighting like hell to ensure that we receive funding, that we enact partnerships that are going to be good for this hospital. We also have to start to think about, what does road B look like? What does row C look like as well? And all of those different paths have to include community input, have to include staff input, and multiple data points and actual discussion about what is best for this hospital. So just thank you for being here today again. I'm very pragmatic, and I apologize for going long, but I know that I just want to be transparent with all of you gathered, and just thank you for your time. So anything else from the board before we adjourn today? Okay, thank you so much. I'm going to adjourn today. Thank you.